Welcome to NCPDP, Unscripted, the podcast where healthcare meets real talk. Each episode, we will dive into unscripted conversations with industry leaders, changemakers, and innovators, discussing the challenges, breakthroughs, and behind-the-scenes stories you won't hear anywhere else. Whether you're on your morning commute or taking a break between meetings, settle in because it's time to get unscripted.
All right, so we are at NCPDP Annual Conference 2026, and I'm super excited to have Seth Joseph here with me on the podcast. So, Seth, welcome to NCPDP Unscripted.
Thank you for having me. I'm super excited because I get to be here with you.
Yeah, thank you. Well, we've known each other for, it seems like 8-9 years probably. Your background, you've got a strategy background, you've got consulting, you're also now a journalist. So let's start there. Tell us a little bit about your background and what you're doing now.
Well, it's fair to say that it's increasingly a longer and longer background. So I've been around in pharmacy since 2007, and in many respects, I think it was, if not the heyday in sort of a modern sense, it certainly was a period of a lot of enthusiasm around community pharmacy.
Yeah.
And at CVS, there was a time of rapid expansion and experimentation with Minute Clinic, and it also was a time where I got to see the very beginnings of e-prescribing, because that was one of the new technologies, and I got to be part of a technology, innovation, and strategy group, and it was a time when e-prescribing accounted for less than 1% of all prescriptions. The vast majority were still paper, phone, or fax. And of course now e-prescribing is the vast majority of all prescriptions nationwide. So I've had the good fortune of sort of getting in at the ground floor as a rising tide of technology has played a role, and we've seen a lot of changes through in and around community pharmacy at the same time. And there's been a lot of change, a lot of it for the positive, and some that has created challenges, certainly for the pharmacy community. But I'm a data-driven optimist, so I'll be happy to share why I'm optimistic.
That's fantastic. So let's dive into that. I know you're a Forbes contributor, and you've done several articles that I've been following for a few years now, and I know you just had one come out comparing the pharmacy industry to Tower Records, which was really fun to read. And I was sharing with you, before we got on, we had a big text message, and it was kind of fun because everyone then shared photos of the Tower Records that they used to go to a long time ago. So it was a great article, but we'd love to just kind of have you dive into it and what you're seeing.
Well, so, I realize I've focused a lot in recent articles around some of the challenges that community pharmacy is facing. But if we step back for a moment and we look at how the pharmacy value chain functions, in many respects, it functions for the healthcare system in a way that very few other parts do. Yeah. And what I mean by that is, if you look at the average cost of a drug to the healthcare system in 2005, I believe it was $58. The average cost of a drug in 2025, last year, was $67.
Really? Interesting.
Really.
Yeah.
So now we can quibble with some of the numbers, and we know that it's not as if that was spread out like peanut butter, as I'm suggesting. But the numbers are what they are. Total drug spend divided by total number of prescriptions dispensed.
Yeah.
We went from $58 to $67, less than a 20% increase in the per unit cost.
Interesting.
If we look at doctor's office visits over the same time period, they increased from $100 on average to $200. If we look at hospital inpatient visits, they increased from 5,000 to between 13 and 18,000.
Wow.
So we're talking about increases of 100% to 150% plus. And so in many respects, what's been happening in pharmacy is, cost containment And I don't want to overstate it. There are challenges with that we're going to get into, and I'll be happy to talk about how this is impacting pharmacy in a way that does, bring the image of Tower Records to bear.
Yeah.
But in some respects, the pharmacy value chain is sort of working in ways we might want other areas of healthcare to work from a cost containment standpoint.
Right.
But there are real challenges.
Yeah. So let's get into some of those. Tell us about those challenges that you see.
Well, so there are myths out there about what's happening to retail pharmacy, community pharmacy, and why they're facing challenges. Myth: Amazon is coming to eat community pharmacy's lunch. Well, Amazon PillPack is a great company, and let's all cheer them on. They're doing right by consumers. It's another option. Competition is a good thing. Mail. Mail is taking pharmacy business away. New technology is taking pharmacy business away. Well, if that were true, we'd expect to see it in the data.
Yeah.
The reality is that pharmacies are filling more prescriptions on a same-store basis than they ever have. They're driving increased revenue. Now, it's modest,
Yeah. Yeah.
from an average of $58 to $67 per prescription, but increased revenue on a per unit basis, and they're filling more prescriptions. They're also holding costs down in a remarkably efficient way, so they're improving operations. All of this is kind of how we want healthcare to work, like a real market.
Right. Yeah.
The challenge is reimbursement
Yeah.
and margin pressure.
Yeah.
We want to applaud the role of PBMs and other entities in holding costs down. We also need to face the recognition that when pharmacies and pharmacists are compensated for their time based on the ingredient cost, and they're not compensated for the value that they bring to the system, that creates challenges. And at the end of the day, that seems to be the biggest challenge. It's not even that Amazon and that e-commerce is taking that much front store business away. That is a real problem for community pharmacy. But those numbers have held fairly constant. It's a gross margin in the pharmacy business challenge related to reimbursement. That's what's, at least to an outsider who looks at the numbers,
Right.
and somebody who's been on the inside, sees.
Yeah. So let's stay on that thread, because the other work that you've done recently is with the NCPDP Foundation grant to start to look at, if pharmacists can do clinical services. And I think, when you think about the reimbursement piece, a lot of pharmacies and pharmacists, especially in the community pharmacy arena, are starting to look to do that. But you found some interesting findings, I think, in the research that you did, and would love to have you share about some of that as well.
Absolutely. Well, I'll start off again with the numbers, because I'm a numbers guy. So in 2022, the then Rite Aid CFO at an investor conference talked about the gross profit that Rite Aid realized from every immunization administration that they delivered. It was $25. That was a really big number, and I understand it's a little bit crude or crass to talk just about numbers when we're talking about healthcare.
Yeah.
But this is the business side of the equation that pharmacies have been facing so many challenges with. $25 was something that the CFO of a publicly traded company was touting in an investor conference because it was twice what Rite Aid made on average for dispensing a prescription. And there are labor costs with both.
Right.
But what pharmacists can look at is $25 of gross profit for immunization administration. That's fantastic business for them. And it's not the only opportunity. There's chronic care counseling, there's gaps in care closures, smoking cessation programs. The list goes on and on in terms of the opportunity. The challenge for them is, how do we make these programs, how do we make people aware of them, and how do we get in network?
Yeah. Yeah, that makes sense. And there were some other challenges too, right? I think one thing that you pointed out was, it's one thing to have, a kind of a panel of patients, right, that you're doing this for. But if you just have one or two, it probably doesn't make sense because they have to basically redo kind of how they're running their stores and how they're doing everything.
Absolutely. So the analogy I'm starting to look at is we're part of an environment now in healthcare in which there's an increasing focus on paying for value, shifting from fee for service to fee for value. And we see a lot of physicians and hospitals and health systems sort of struggling where they're straddling two separate business models. The predominant majority of their business is still fee for service, and yet where the world is going is fee for value. And so they're trying to invest in population health programs and caring for patients on an ongoing basis, and that requires a really different operational mindset and set of workflows and technology that's really hard to optimize for when you're straddling two models.
Right.
And that's what pharmacies are facing. We spoke with a pharmacist, and a pharmacist who's part of a larger organization, who said, we love these programs. It's really hard to optimize for them when we have one patient coming in a week.
Yeah, yeah.
That's not the focus of our business. And the trap that creates is if the vast majority of their business and their volume is still dispensing fee-based, that's what ultimately is supporting the business. That's where they're going to continue to pour their resources into continually optimizing it. And so we need something to sort of break this cold start problem where pharmacies want to provide services. It seems like a lot of health plans are interested in working with and partnering with pharmacies. And we see PBMs as well who are seeking to, but they haven't scaled yet.
Right, right. So what do you think we're going to have to do to scale that? Like,
Oh, I'm so glad you asked me this question.
Yeah.
Well, it's not going to be easy work. But we've seen this type of cold start problem play out in the past. We saw it with e-prescribing. So with e-prescribing, we think that, we look back on it now and we say, well, e-prescribing was always going to happen, and 99% of prescriptions now are e-prescribed. Why is this a big deal? It's a big deal because it didn't happen by chance.
Right.
It happened with an extraordinary amount of effort. There were federal pilots. There was testing of standards. NCPDP was a huge part of this.
Yep.
There was SureScripts, a national network providing the infrastructure. There were EHRs. There were pharmacy systems. But what the fundamental challenge was, from a network building basis, was we couldn't get doctors to adopt. And we couldn't get doctors to adopt because pharmacies hadn't really adopted. And pharmacies weren't adopting because doctors weren't adopting. So this cold start problem. And what worked in the early days of e-prescribing were local, regional, state-based initiatives to pull together stakeholders, to educate stakeholders on the technology, on the benefits to doctors, to pharmacies, to the healthcare system, to pull together constituents to start getting some early adopters, to prove out that there was value in the network and in the whole e-prescribing ecosystem, and then to start to scale that effort out amongst the community. We saw that in Michigan, in Massachusetts, in Rhode Island. And if we look back at where the data was of early adopters, it's in those states. And so what we think is necessary based on what we heard in our interviews of 30 interview experts across health plans, across PBMs, across chain pharmacies, independents, federal agency representatives, and academics, was there are real operational barriers to solve. But the strategic challenge is a cold start problem. And so what we think is needed are local, regional initiatives, which we are calling Pharmacy Health Alliances for Reimbursable Medical Services, or FARMS.
Okay. Love it.
to pull together initiatives, because the reality is that while there's an incredible amount of innovation occurring, and we see this in states in Arkansas, we see this in Ohio, in North Carolina, the challenge is if, for instance, in North Carolina, Blue Cross Blue Shield of North Carolina, with their Medicaid population, is running an incredibly innovative program, they want to make sure all pharmacies are participating, but that one line of business isn't going to be enough to drive enough volume to those pharmacies. We need not just Medicaid, we need the entirety of Blue Cross Blue Shield North Carolina. We need other health plans in North Carolina to participate, and we need them to align on services. We need to talk through how they're going to handle credentialing, enrollment, reimbursement, billing, data collection, et cetera. These are hard problems, but they are workable problems at the local level.
Yeah, no, that's great. And I love, seems to be a lot of initiatives around this. So I feel like it's that probably the time is right. So I could probably sit here and talk all day with you. I love all the stuff that you're working on, but I got to wrap it up. So you started out by saying what you're hopeful for. You said you would share what you're hopeful for. Curious what that is.
Necessity is the mother of all invention. Necessity is also the mother of all innovation. Community pharmacy needs to evolve, and the healthcare system will be far, far better off when it is able to take advantage of the rich clinical resources that pharmacists are and can provide.
Yeah.
I think we're getting there.
Oh, I agree. Fantastic. Well, Seth, it was a pleasure having you on the podcast. I'm glad we had a chance to sit down while you're here. And look forward to seeing what happens with these farms.
Likewise. Thanks, Pooja.
Yeah.
That's a wrap on this episode of NCPDP Unscripted. Thanks for joining us as we explore the voices and ideas driving innovation in healthcare. If you'd like to be a guest on the show or have topic ideas you'd love to hear us cover, we want to hear from you. Until next time, stay curious, stay connected, and stay unscripted. Our podcast is proudly sponsored by Marks Productions.